Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Linda Brubaker. I'm an associate editor for JAMA and a clinical professor at the University of California in San Diego. I'm really pleased to be joined today by two outstanding guests, Dr. Rebecca Cohen and Dr. Stephanie Teal, who co-authored a patient page for JAMA on the topic of medication abortion.
My name is Rebecca Cohen. I am an associate professor at the University of Colorado, where I also serve as division chief for complex family planning and the medical director of an outpatient abortion clinic.
I'm Stephanie Teal, and I'm the obstetrician gynecologist in chief for University Hospitals Cleveland Medical Center and the Arthur H. Bill Professor and Chair of OBGYN and Reproductive Biology at Case Western Reserve University School of Medicine.
It's a pleasure to have you both with us today on this very salient topic. There has been a tremendous amount of evidence regarding medication abortion over the years, but this topic is ever more important now in the light of the recent Supreme Court decision. So even prior to the recent Supreme Court decision in the Dobbs case, medication abortion was increasing. Dr. Teal, could you talk a little bit about why this was happening? Why was there an increase in medication abortion?
Medication abortion was approved in the U.S. actually over 20 years ago now, and it has become the method of choice for American women in the first trimester because of a couple of characteristics that distinguish it from procedural abortion. First, the timing can be controlled by the pregnant individual. They can decide to use the medication in the privacy of their own home. And for many people, it feels more natural to them.
That's a very important point. Some people wonder what is the difference between a spontaneous abortion, also called miscarriage, and a medication abortion. What physiologically happens?
Interestingly, they're actually quite similar. Medication abortion uses two medications. The first, Mifepristone, is a progesterone antagonist, which causes the pregnancy to detach from the lining of the uterus. In a spontaneous abortion, progesterone levels naturally go down, so it's the same effect. These progesterone receptors are seeing less progesterone, either because they're blocked by the medication or simply because in the spontaneous abortion instance, the progesterone level just gradually diminishes on its own due to the loss of the viability of the pregnancy. Then the second medication is a prostaglandin, which again can be administered pharmacologically or occurs naturally to cause uterine contractions, cervical softening, and opening and expulsion of the products of conception.
Dr. Cohen, I wonder if you would talk a little bit about the counseling that you and your colleagues provide to patients considering medication abortion as an option.
The first thing that we do is ensure that a patient is coming to their decision free of coercion, that they're not being forced by anyone in their life to terminate the pregnancy. Once they've made that clear and they let us know that yes, ending the pregnancy is the right thing for them in this moment, we talk about the various options. So for anyone under 11 weeks of pregnancy, they are able to opt either for medication abortion or procedural abortion. And we talk through their preferences, their values, and their ability to follow up with us in case there is a problem. So for someone who wants things done quickly, we do talk about a procedural abortion in the office or a DNC, dilation and curettage, which is about a 5 to 10 minute procedure with or without sedation as they choose. For people that are interested in medication abortion, we do talk them through the process. So what to expect over what time period, and we assess their ability to know or to understand what is normal, what is not, and whether they're able to reach out if there is a concern, since everything does take place typically at home.
Dr. Cohen, how effective is medication abortion?
So it depends on the stage of gestation. So very early in pregnancy, about 6 to 7 weeks, it's more than 98% effective. But even later in the period when medication abortion can be offered, up to about 10 or 11 weeks, it's still about 95% effective. And that is measured a little differently in different studies. But for most, that success rate is defined as passage of the pregnancy without any additional medication or procedure.
Dr. Teal, there are certainly going to be patients for whom medication abortion is not an option. Could you tell us about who those patients might be?
Patients who do not make good candidates for medication abortion are people who are anemic, who are in a social situation in which they don't have a safe and private place to undergo the pregnancy loss, which is accompanied by passage of clots and bleeding. Of course, if they're allergic to Mifepristone or Misoprostol, they have a bleeding disorder. I think I mentioned severe anemia. If they have adrenal gland dysfunction, they're on long-term corticosteroids. So really, very few patients are excluded medically. I think it's important to point out that this treatment is only effective for intrauterine pregnancies. So if there's a suspicion that this is an ectopic pregnancy, medication abortion will not treat that pregnancy and in fact can lead to delayed diagnosis and management.
Dr. Cohen, is it recommended that patients considering medication abortion have routine ultrasound prior to initiating medication abortion?
Most patients who are opting for medication abortion do not need an ultrasound. For someone that has regular periods, meaning predictable periods every month, and is under 11 weeks gestational age, most can have medication abortion without an ultrasound. We do recommend ultrasounds for people with unsure menstrual periods or irregular menstrual periods where the gestational age may be much greater than they expect, or for people that are at high risk for ectopic pregnancy, things like becoming pregnant with an IUD in place after pelvic inflammatory disease or after a tubal ligation, or people that have clinical suspicion for ectopic, so vaginal bleeding or severe, persistent, or one-sided abdominal pain. For those people, they would definitely need an ultrasound, but they are in the minority of people seeking medication abortion.
And is there a shelf life for this medication, Dr. Teal? If the patient has the medication, then ends up not using it, can they use it 6 months later or 12 months later?
The shelf life of Mifepristone is actually 5 years, and of Misoprostol is 2 years, as long as it's kept in its original packaging and in a cool, dry place.
Dr. Cohen, I think it would be helpful for our listeners to describe the experience that a patient would have as they proceed through a medication abortion. What is that experience like?
So in my counseling, I do let our patients know that every person is different, every body is different, every experience is different. But the majority of people, especially those who've experienced miscarriage before, it's like that. We talk to people that after they take the Mifepristone, the majority will not have significant side effects. People may have a little bit of nausea or a little bit of spotting, but most people that take Mifepristone will not feel any differently, and that's to be expected. What we do tell people is that when they take the Misoprostol, either in the cheek or in the vagina to dissolve, is when they start to have side effects. And so for most people, that starts within about 2 hours of using the Misoprostol. They'll start to have cramping and spotting that over several hours will progress to symptoms that for almost everyone is more intense than a period. So they'll have strong cramping that can last for several hours. They'll have bleeding that for most people is heavier than a period, with passage of blood clots, and depending on the gestational age, they may also see white or gray tissue. After the passage of the pregnancy, the cramping will get a lot less intense and the bleeding will lighten up, although it's normal for people to have cramping for a day or two after and light bleeding even up to 6 weeks. For most people, though, from the time that they use the Misoprostol until the pregnancy passes and things improve is usually about 6 to 8 hours.
I suspect that given your experience, you've encountered a patient who took the first medication, the Mifepristone, but didn't go on to take the prostaglandin. What happens in this situation?
So that's something that we don't have great data on. What we know is that the vast majority of people, once they plan to have an abortion, they will complete the process. However, rarely there are people that will take the mifepristone and not take the misoprostol. What we know is that even with mifepristone alone, more than half of the time the pregnancy will end, but that there are a few cases where without intervention, the pregnancy will continue. We know that it does place the pregnancy at higher risk. There's often partial detachment of the pregnancy from the uterine lining, the uterine wall, and so that's higher risk for later miscarriage and bleeding throughout the pregnancy. We also know that taking mifepristone without misoprostol can be dangerous. There is a study that was done looking at, because mifepristone is a progesterone antagonist, comparing a placebo versus a high load of progesterone to see whether that would improve the chances of pregnancy continuation. But that study was actually stopped early because of a significant risk of hemorrhage and danger to the people in the trial. So it's something that we don't recommend. As part of our counseling, we talk to people about, if you're not sure, the safest thing to do is to not start the process at all.
I wonder if you could tell us about the other risks that we haven't talked about for medication abortion, Dr. Teal.
The biggest risk is excessive blood loss. And so I believe Dr. Cohen touched on this, but it's important to counsel the patient that she will experience blood loss. That is absolutely a normal part of the process. However, if she's soaking through menstrual protection, we usually say 2 maxi pads, large pads per hour, 2 hours in a row. Then she should call just to at least discuss how much she's bleeding. Is it increasing or is it decreasing? There is no risk, and I think this is really important for patients to hear because it's a concern. There is no risk to future fertility. There is no increased risk of any breast cancer or other cancers related to mifepristone or misoprostol use. There is no increased risk of thrombosis. Sometimes people can be confused about birth control pills and wonder if that is a possible risk. Really, it is more the hemorrhage. Now, there have been some reports of infection after medication abortion, and so we definitely want to counsel patients that should they have a fever, even low-grade abdominal pain, a flu-like syndrome, more than 24 hours after the process, they should contact their clinician. And then, as Dr. Cohen brought up, there is a small risk of retained products of conception. And so if the patient continues to have bleeding or cramping, we do ask her to come in for an ultrasound.
Thank you, Dr. Teal. And Dr. Cohen, could you talk with us a little bit about your experience in recommendations for how the termination of pregnancy is confirmed and whether it's necessary or routine?
So the most important thing is to acknowledge that patients typically recognize when things have not gone as they've expected. So we talk them through, here's what to expect. And if you don't have cramping or don't have bleeding within 24 hours of taking the misoprostol, please call us. That means that it didn't work. But as long as everything goes as expected, there are typically 2 pathways for confirming that the pregnancy has passed. What used to be required in almost all places was an in-person follow-up visit, and that would involve typically an ultrasound to confirm that the gestational sac had passed from the uterus, to ensure that their endometrial stripe wasn't too thick, although we know that there's really not a number that says that there's too much material within the uterus and we need to intervene. And so that was primarily to ensure that the gestational sac had passed. With COVID and the need to really limit people's in-person interactions or to really adjust that balance of what is needed in these situations, alternative methods were developed that were found to be as safe and preferred by patients because it saved an additional office visit. And so our Our office now does offer still an in-person ultrasound if a patient wants it, but we also have an option for remote follow-up, which is a phone call 1 week after the Misoprostol, so to ensure that, yes, people had cramping, they had bleeding, and they also had resolution of pregnancy symptoms, which we expect about 3 to 4 days after passing the pregnancy. And as long as everything sounds good on the phone, we have them take a pregnancy test in 1 month, after which time we expect that the HCG will be undetectable. And if it is positive at that time, we ask that they call us, but most are negative and are able to assess the completion on their own.
HCG is the hormone human chorionic gonadotropin produced by the cells that become the placenta. This is the basis for most pregnancy tests. Dr. Teal, it sounds like medication abortion has a growing literature to support its safety and efficacy. Would you agree that this is a safe technique for voluntary interruption of early pregnancy in most pregnant individuals?
We have over 20 years of experience in the United States with medication abortion. Millions of women have used Mifepristone and Misoprostol to interrupt their early pregnancies, and the data is very, very clear that in the vast majority of cases, the process occurs as it should and results in the desired and expected outcome with very few complications. So we can feel very, very comfortable recommending that if somebody wants to terminate an early pregnancy, they can choose either a procedural abortion or a medication abortion based on her values, her desires, what works in her family setting, again, with just a few contraindications. You mentioned the development over the last 20 years of scientific evidence supporting medication abortion. When medication abortion was first introduced in this country, it actually had a very different regimen. But because of a great deal of evidence that has accrued over the decades, we now can use lower doses of the Mifepristone. People have more choice in when they take the second medication, which is what actually sets off the bleeding and the miscarriage, so they can do that at a time that works for their family. They now, as Dr. Cohen mentioned, have more options for post-termination follow-up. We have good data now on the use of contraception after pregnancy termination. So the scientific evidence has really benefited individuals who are in need of this treatment.
I'm glad you mentioned contraception because I suspect contraception is an important discussion around this procedure. Dr. Cohen, would you talk briefly about contraception options and when patients should restart contraception?
Absolutely. So we do offer contraception to any patient that is undergoing medication abortion because we know that fertility comes back rapidly after the end of a pregnancy. So for people who choose a patient-administered method, so either pills, patch, or the ring, they can start that as soon as the pregnancy has passed. Sometimes with remote follow-up, we do counsel them to wait until the phone call because new start hormone symptoms for some people can mimic symptoms of pregnancy and make that confusing, but they are able physiologically to start as soon as the pregnancy has passed. We can also place the contraceptive implant in the arm at the same time as initiating medication abortion, and we can offer injectable contraception or Depo-Provera at the same time with careful counseling that it may slightly increase the risk of ongoing pregnancy, although not increase the overall intervention rate. For someone that wants an IUD, we do have to make a second appointment to place the IUD once the pregnancy has passed. For someone considering permanent contraception or tubal ligation, we can do that shortly after passage of the pregnancy as well, as long as they understand and are able to confirm that the positive pregnancy test won't interfere with the hospital procedures or pre-op counseling in that case.
I want to make sure that we don't lose sight of the importance of existing racial and ethnic and socioeconomic disparities that we know pervade healthcare, and this is very much an issue, especially in this area. I wonder, Dr. Cohen, if you would comment on how new legal restrictions exacerbate these existing disparities.
There's a lot of levels to that, but truly what we know is that the new legal restrictions harm people who are already the most marginalized. That new restrictions on abortion are overwhelmingly occurring in states which already have limited safety net for people that are considering raising families or faced with unplanned pregnancies. We also know that people who don't speak English as a first language, people who are non-citizens of the United States, young people, and people who are ethnic and racial minorities have difficulty seeking care. Now that that legal restriction is making it even more difficult to seek care, it means that they have less access to safe abortion and are also less likely to come forward with a concern or medical complication because they fear the legal repercussions. So the changes are significant, and we know that they are exacerbating the inequities that are already occurring.
Thank you for sharing that with us. I wish we had more time to go into depth on this very important topic, but we do need to bring today's podcast to a close. I want to express our sincere thanks to our podcast guests, Dr. Rebecca Cohen and Dr. Stephanie Teal. Thank you very much for joining us today with your expertise. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Jesse McQuarters, Daniel Morrow, Lisa Harden, Audrey Foreman, and Marilyn Furkuluk. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.